Good morning and welcome to the 11th Health and Sport Committee in 2020. I thank all members for attendance today in these very unusual circumstances and thank all our parliamentary staff, in particular the Broadcasting Office, for all the hard work involved in setting up this remote formal meeting of the committee. We recognise the very challenging times in which we are living, and we pay tribute to all of the organisations in the health and care sectors for their continued dedicated service and hard work at this time. Can I please ask all members to ensure that mobile phones are on silent? The first item on our agenda is our second public evidence session on the Forensic Medical Services Victims of Sexual Offences Scotland Bill at Stage 1. Scrutiny of the bill began in February and was subsequently delayed due to the pandemic. We will now be taking evidence during May and June with the intention that Stage 1 of the bill will be completed in the Scottish Parliament in autumn 2020, if indeed it is approved. The session today is to discuss a range of issues with NHS boards, with NHS Lanarkshire attending, and I welcome to the committee Dr. Anne McClellan, Consultant in Sexual and Reproductive Health with NHS Lanarkshire. Dr. McClellan, thank you for joining us today. Due to the challenges of managing a virtual meeting such as this, we're going to take questions in a pre-arranged order. I will ask the first question and then invite others to ask their questions in order. Can I ask both our witness and members to keep questions succinct and also to allow a few moments before you start to speak to allow broadcasting staff to operate your microphones before beginning to ask a question or to provide an answer. And can I ask members as well, when you're asking a number of questions, please indicate when you're on your final question so that broadcasting staff can be ready to move on to the next member. I will start in a moment and then I'll be followed by Sandra White. Dr. McClellan, we've heard a lot of evidence already about the issue of examinations and examination places and how important an appropriate place is for those involved. And I wonder what your view is of whether appropriate facilities are already in place or will be required to allow the successful implementation of the bill. Dr. McClellan.
I think quite a lot of work has been done on establishing capital projects and boards to have a suitable premises host, move the examination site out of police custody into healthcare facilities or sites near healthcare. That's very important. And certainly in Lanarkshire, we are getting ready. We're almost ready with a facility in the grounds of Wishaw Hospital, but not in the hospital, which will be more user-friendly, I hope. And I think other boards are moving in a similar directions. There's been good work in Larbert, I know, and I'm not sure of all the other boards, but most boards are moving to improve premises, which would be much. Yes, that's a good step forward, and we welcome that.
And so, in terms of premises, you think the boards are on board? They have plans taken forward. In terms of workforce, I guess that's the other question. In terms of for the examination side, are workforce plans in place? Are workforce already there, or what is your prognosis for development on that side?
So the workforce is a challenge, particularly with regard to the gender of the examiner, and that's going to be a challenge in the next year or two. However, the West of Scotland certainly is making big steps to improve the workforce and improve the number of female forensic examiners. There's also been a good training programme nationally to try and encourage female forensic examiners to come together. I think we should have a network for female forensic examiners across Scotland. I think the bill is a welcome improvement to improve the care of victims or survivors or people. But I think a network of examiners would be really good across the whole of Scotland. The workforce is challenging, but there's ways that it can be facilitated. And what I mean by that is there are sexual health staff in every health board at the moment who are used to seeing patients who've had sexual assault but haven't involved the police. So there's a body of work of staff there who can be tapped into with the appropriate training, and I think that's the way we need to go forward. It is still going to be challenging to provide a 24/7 service of high quality and maintain the skills in some of the quieter or more rural boards, but it's doable with a network and also remote training, to update. So I would anticipate for Lanarkshire, some of the staff that we've put forward who are eminently suitable to be forensic examiners may be working in a different site and not in the centre of excellence, but be linking in with them for updates, or doing virtual training, keep them all skilled and to have a consistent approach. So I think it's challenging, but I think we can do it.
And if I understand you rightly, you're saying essentially that networking is the way to deliver that 24/7 service, which clearly would make a huge difference to those involved. Can I ask, I think you mentioned in that answer work that was being done at West of Scotland level. So do I take it from that the three regions of North, West and East are already working on a regional basis to identify people, female forensic examiners in particular, and to create the kind of network you're talking about?
Yes, I think they are. I think that certainly most of my experience is the West of Scotland, but the national event, there's been national training, so other boards areas are linking in. Yes.
That's very helpful. Thank you very much. Yeah, carry on.
I'm not worried about the rural. Obviously, if you don't see so many cases in a rural area per year, there will be mandates that you need to see so many cases to skills up. But I actually think there's so much movement now to remote working and virtual working, partly because of Corona. People are going to be very familiar with doing remote consultations or remote supervision. So there's ways we can get around that.
That's very interesting. I'm sure it's something we'll follow up with the three regions, and I'm also very interested already to hear how coronavirus and the changes that's made is already creating new possibilities for training and so on. So that's very encouraging. Can I now move on and invite Sandra White to ask her question? Sandra White.
Thank you very much, Convener, and good morning, Dr. McClellan. Many issues has been raised, and I think your own health board raised it also, about the retention of evidence in regards to recording, storage, data, etc., and also the cost to health boards. Could you give us your opinion on how you think the retention services should operate?
With the retention service, we have to be sensible here. There are going to be more people coming forward, I'm sure, after this bill, and maybe also more people self-referring. And the problem will be large items of storage, such as a duvet or clothing. If we were going to take all of that on board for an indefinite period of time, I think that's unrealistic. However, at the moment, the retention of samples for self-referrals is mainly swabs, is only swabs. So I think we need to there's a compromise here. Once we know the time for the retention, so if that's decided to be 3 months or 6 months, then also we can make that time that after that the evidence is destroyed. I know that's up for debate, the time scale. But the other thing is we could opt to say that clothing, duvets, large items can't be stored beyond a certain time, whatever happens, but we keep the forensic swabs because the swabs are smaller and also they require to be in a freezer. So there will need to be capacity for freezer storage. Who owns the samples is possibly challenging, but I think, again, that can be worked around. I think, if we agree that these samples are taken on a health board premises, then we need to decide they're health samples till they're destroyed and they need to be managed properly. If a self-referrer decides to go down the police route, these samples need to then be transferred into Police Scotland or Scottish Police Authority. So I think that's workable. From a practical point of view, we cannot store loads of stuff for years, and certainly indefinitely. What we could do is limit it to swabs only, limit the time. And the only thing I would say about that is for younger children, or maybe adolescent, younger children. I'm not really a paediatrician, but for example, for health records, for sexual health records, we only keep these for 8 years for most of the population. But for young people, we keep their records till they're 25. That is in case things come out later. So we may have to think about the young people coming in, how long we store that. So that would be something for the paediatricians, though, to decide with the police. I'm not a child examiner. I don't examine people under 13. Does that make sense?
Thank you for it. It does actually, and it opens up another avenue. And you mentioned about the retention. You would probably say a two-track approach where swabs would be kept longer, not indefinitely, but bigger items maybe just a couple of months. That's an interesting aspect of it in that respect. On the issue of ownership, obviously it's a very delicate situation in regards to that, and there's data which is stored also. Now, I just wondered, it's been suggested by the Commissioner, Information Commissioner, that perhaps we should look at a data protection impact assessment. Do you think that would be a good way to go forward in that?
For the ownership, my understanding is that I find this a bit confusing myself, but my understanding is that the concern is that you're retaining swabs of another person without their knowledge. And yes, I think you need to take advice from the Data Commissioner on that. Just to go back to the larger items, can I just say the one solution would be to photograph the larger items. So at least there would be some evidence that wouldn't have the DNA analysis on it, but you could photograph the items before they're discarded. But certainly once they were released. Sorry.
No, not at all. I mean, I'm interested in what you've said there, but I think you've answered the questions that I wanted to ask. So that was my last question, but thank you so much.
Thank you very much. David Torrance.
Oh, I can't hear.
David Torrance.
I can't hear him. Apologies. I can't hear him.
Can you hear me now, Dr. McClellan?
I can hear you now, yes. I can hear you now.
Thank you. Talked that the bill will address service variation across Scotland by standardising FME services that are in place in both urban and rural communities. Dr. McClellan, what is needed to ensure that a consistent service can be delivered across Scotland?
Anne McClellan.
Well, I think there's an appetite and a will among the female workforce in Scotland to deliver this, and I attended the update training with Nez, and there are a lot of good female doctors who are willing and already working in these services. I think, as I say, a network with national updates, and I really do think it should be once for Scotland. I think we should be providing consistent services. I don't see big challenges in that, apart from some people in rural areas maybe not seeing the volume of cases. But I think there's potential to bring them into the bigger centres for maybe a week, a year, or to do virtual consultations where they have mentoring. But I absolutely think we really need to try and get an equitable service across all the boards. And I think putting the premises near patients or near is good, but we need to have very clear pathways and the same pathway operating, or a similar pathway operating with the same level of commitment from clinicians, from police, from voluntary sector, so that wherever you present in Scotland, you will get a quality service with a seamless provision of care, a seamless provision and a high quality care.
David Torrance.
And finally, Dr. McClellan, is there a risk that health boards will implement the legislation in different ways, leading to a variation in service provision across Scotland?
Anne McClellan.
Yes, I suppose that is a risk. It is a risk. However, I think if this bill goes through, there'll have to be an agreement, perhaps by, for example, the lead clinicians in sexual health are a group who every single board in Scotland has a lead clinician for sexual health. They are employed by the health board, and they need to be driving this forward to make sure that we don't do things differently, or that we come up with a minimum that must be delivered, so that as a benchmark. I think that, to be fair, the data we're getting better data now, and there is a subgroup of the task force looking at data. So there must be an ongoing quality assurance process here, is what I think is what I'm trying to say. We must be looking at how many people are seen within 3 hours, how many have looking at the indicators, how many have the choice of gender examiner, how many weren't able to be seen because the suite was in use, all of these things. And there needs to be a stepwise implementation of here. This could be a huge project if we open a new bill encouraging self-referral across Scotland, loads of awareness raising. We could be totally inundated. I don't think that will happen if we do it in a logical, stepwise fashion, and we must keep the smaller boards on board with everything that's happening. It can't just be a Glasgow and Edinburgh project, essentially. But I think we'll get there. I think we'll get there. The quiz standards will help that.
Thank you very much. George Adam, on that very subject.
Thank you, Convener. Just on that point, Dr. McClellan, and good morning. I would like to ask, you already said that the West of Scotland was ahead in this area, but what would be the difference, if we're talking about consistency of service across Scotland, what would be the difference between the West of Scotland and some rural areas, or maybe even some rural areas within the West of Scotland?
Anne McClellan.
I don't think that the only reason the West of Scotland's ahead is because they have traditionally had the Archway service, which was the first functioning sexual assault referral centre really in Scotland. Actually, they've had huge problems with recruitment and service provision, so it hasn't all gone smoothly in the West of Scotland. But with the model proposed, the task force, that there's a centre of excellence and then basically a hub and spoke model. It'll be necessary to identify centres of excellence that support the smaller boards. I'm quite clear about that. So there are things that could be done which are not in, actually. But for example, for sexual health services, there were quiz standards which said we had to provide 12 hours of clinical care within every settlement of 150,000 people. So there are things that can be done to say we would expect patients to be seen within X amount of hours of the time, or we would expect a rural person not to have to travel further than X amount of miles. So I think there are things we can do out with the bill, looking at clinical service provision. That's what I'm trying to say. If the clinicians get behind it, which they will if they're given direction from the health boards, hopefully.
Thank you very much. Thank you. George Adam.
Finally, Dr. McClelland, is there any guidance you would like to see from the Scottish Government on the examination and retention service itself?
Anne McClellan.
Well, I think there has to be consistent. I think there has to be regulation of the training so that all forensic examiners are of a certain standard, doing a certain number of cases and linking into a centre of excellence. I think the retention, to be honest, I think that might have to, the length of being samples may become a problem. Obviously somebody can report a sexual assault for life, but we can't keep samples for indefinitely for people who have on a self-referral basis who may not or may not report. And even for people who, even if we do allow storage of samples, I'm not sure it's realistic to store big items for life for the whole population. I think that would be difficult. It would be good in a way because you would have that DNA evidence for 30 years, and you've seen the cold cases now coming into to be settled 30 years later. But if the large items are discarded and there are still swabs with DNA, we would still have that DNA. The only thing I think, which is not on this bill or in anybody's mind, would be should there be an anonymous DNA database? But that would be a whole piece of work of its own. So in other words, should DNA samples be taken and be stored and be analysed and stored in an anonymous database? That might be useful if you had the same DNA appearing 4 or 5 times, weren't reported, even if it hadn't been a reported crime. If that makes sense.
Thank you very much. I have a brief supplementary from Emma Harper, and then I'll come to David Stewart. Emma Harper.
Thank you, Convener. It was just to pick up on what Dr. McClellan said about the 3-hour issue of, I guess, needing to have that window of availability or the ability to have an examination in 3 hours. Some of the early data that's come out of the self-referral service in Dumfries and Galloway shows that there was a peak of self-referrals on a Wednesday, and it didn't really relate to the person having an assault on a Saturday or a Sunday or a Monday or a Tuesday. I'm just wondering if that's a factor that would be gathered in any data collection as we're looking at moving forward for this.
McLean.
So I think the 3 hour is just arbitrary. That's just an arbitrary standard that patients should be seeing 3 hours. So, and it would be really unfortunately if you've only one examining room and there's 3 people present at the same time in Dumfries, then you're not going to manage that target. But we should still aim to examine people within 3 hours, because they can't shower or wash till they've been examined, etc. So, but I think when we report on the 3 hour target, we have to say 2 patients weren't examined because the suite was already in use. So one waited 6 hours and one waited 9. Or we give that patient the option of travelling. If it's going to be quicker for somebody from Dumfries to travel, not quite sure if you could get to Lanarkshire in under 6 hours. Yes, you could. So if the Lanarkshire suite was free, they could go to a different suite rather than wait 6, or put them or at least one of them go and then nobody's waiting 9 hours. Does that make sense?
Yep. Okay.
But I think we've had long waits, even in Glasgow. There have been patients waiting overnight, patients waiting over weekends in the last year or 2 when staffing have been a major issue, without being able to have a shower. And a lot of people will just not do that. They'll just decide they're not going to pursue things. Most people would not want to wait over 48 hours to have a shower if they did a sexual assault.
Mm-hmm.
Thank you very much. David Stewart.
Thank you, Convener. Good morning, Dr. McLaren. Could I move on to discuss the role of professional judgment? The explanatory notes confirm that the bill does not confer on individuals a right to have a forensic medical examination. Examinations would only be carried out on the professional judgment of a healthcare professional. Could you expand on this? What would it mean in practice?
Yeah, well, I think the first thing is it is difficult. I'm with you on this, actually. I think what they mean is if somebody presented at 9 days post-assault, there's no point in doing doing a forensic examination to capture DNA. I think that's what it means. So they could demand a forensic examination, but it would be inappropriate because you're not going to capture DNA. That makes sense. So they wouldn't have a forensic examination for DNA, but if a patient demanded that they were looked at and they had a bruise, I think that our professional judgment would be we would look at that bruise, document that injury. It's just they wouldn't do the full swabs because you're not going to get DNA. This may change as DNA tests get better and it goes to 10 days because some DNA tests do pick up, but we're not quite there yet. And throughout Scotland, it was 7 days for DNA.
Yeah, no, thanks. I think that's very clear. You've given a good example of a clinical aspect to professional judgment. There's also non-clinical factors would come to mind. Could you give an example of that? So, for example, would you then assess the age or maturity of the individual before making a decision to go ahead?
Yes. So I was trying to think of some scenarios where you would not do a forensic examination and the patient was really keen to have one. I think there's a few things. It's not about consent. It may be inappropriate. Suppose somebody was acutely psychotic, for example. Again, that's probably clinical. It would not be appropriate maybe to do forensics. There are workarounds to that. I would probably, if somebody was acutely psychotic, we may not be able to do it. Now, we might be able to do it if we had, if it was serious and there was, they'd been badly injured, then, and we felt this patient needs examined, even if it's not for forensics, they need examined. We capture the forensics at the same time. We would need to ask, we would probably need to take legal advice on that, to be honest. I'd probably either from the defence union, but obviously the psychiatrist. I mean, I'm sort of thinking about fluctuating capacity. It would be unusual for somebody who was acutely psychotic to demand a forensic examination, not need one. But that could happen. It could happen.
Sure. You mentioned legal. That takes me nicely on to my next question. How important is the guidance of the Faculty of Forensic and Legal Medicine? Presumably having Scotland-wide consistency is really important.
Well, yes, it is. And unfortunately, sometimes, as you know, the law in England and Scotland can be a bit different. But for things like retention of samples, guidance and clinical stuff matters, the faculty is useful. It's only come into its own in the last few years. So at the moment, the training has changed a lot. It's better that people do train through the Faculty of Legal Forensic Medicine. But 5-10 years ago, that wasn't mandatory. So it can be difficult for us because the legal situation in England and Scotland can be different. So the training in Scotland has got to reflect the legal process in Scotland, and the doctors in Scotland have got to work to that. Does that make sense?
It does. My final question, is there a wider philosophical issue here about patient rights versus professional judgment? I'm thinking here about the European Convention of Human Rights. It may not be an area of expertise you have in that particular aspect, but is there any dilemma do you see in the legislation or the future legislation around this?
Anne McLeod.
Well, I think there could be a dilemma for adolescents. So there's two things I think. I think that all people have a right to have good clinical care. All people have a right to have forensics captured if it's indicated. The bit I find challenging here is for human rights. I'm not sure what the human rights are if the alleged perpetrator's DNA is captured, stored, whether it's destroyed or not. So I'm not sure about that aspect of human rights. I think there would be very few situations where the human rights of a patient they would never be overruled, I don't think, by a doctor in a forensic setting. I would be very surprised at that. I think that most doctors are empathetic, sensible, and if they have any doubt about a dilemma with a human rights aspect or challenging things like capacity or where a patient's where the doctors are not in tune with what the patient wants, then they can take advice from more senior people. They can take advice from their defence union. There are channels for these things to be sorted out sensibly in Scotland, not in front of a court. It might need to go in front of a sheriff, but most of the time in Scotland, with good working with multidisciplinary teams, taking the right advice from the relevant professionals, we would hope not to go into in front of a sheriff unless we needed to, if that makes sense.
Thank you.
Very much. I'm sure we'll come back to these issues in a future witness session around legal rights and the justice system. Can I now move on to hear from Alex Cole-Hamilton, who will be followed by Emma Hart. Alex Cole-Hamilton.
Thank you, Convener. Good morning, Dr. McClellan. Thank you very much for your evidence so far. Can I ask, do you think that the self-referral should be only available to people aged over the age of 16? And what is the basis, you think, if that should be the case, if you do agree with that?
Anne McLeod.
Well, to be honest, I think there are a lot. I think it's going to be. This is one of the most difficult areas. I think we should be encouraging self-referral in 13 to 15-year-olds. I think we should encourage that, because I think if you look at the sexual assaults in years for last year's 13,000 sexual assaults, 40% were in under 18s. I think we see a lot of adolescents coming in who are 1 in 4 under 16-year-olds in Scotland is sexually active. There are a lot of challenging scenarios. It's not an easy area. An adolescent who would potentially come in, then refuse police involvement. That's the big challenge. However, we can encourage that I think we need to encourage them to come forward for clinical care. I think they need to be supported by an advocacy worker, maybe a youth specialist, to involve police. Obviously, if there's a clear child protection barn door, we have to involve the police. But there are certain scenarios that are difficult. For example, 2 14-year-olds go to a party, they get drunk, go into the bushes. One of them wakes up with all their clothes on inside out and something's happened and they feel sore down below. Now, if they came in, to say that all under 16s must involve the police with no consideration of different circumstances, I think we're going to have a missed opportunity here for having adolescents coming forward, I think.
Thank you very much. Alistair Hampton.
Thank you, Convener. So my anxiety, obviously, about restricting, I share your concerns about restricting, not least because obviously if sexual abuse happens in the home, a sexual assault happens in the home at the hands of perhaps of an older family member, it's going to be much harder for that person to find an appropriate adult to come with them or to talk to somebody in their social network. Can I ask what happens at the moment? Say, for example, a 14-year-old is assaulted or raped and then appears at the archway. What is the protocol for self-referrals when children try to self-refer at this time?
Anne McLeod.
So there is no capacity for under 16 self-refer in Archway at the moment.
So would they just...
Yes, well, if they came in to a sexual health service, most of them come in if it was out with 7 days, you can't do the forensics anyway. Right, but what happens at the moment is, even in any sexual health service, forgetting about Archway, if an under 16 came in, they would get clinical care. All under 16s in sexual health services have a risk assessment performed, whether they've been sexually assaulted or not. So we're looking at the age of the partner. Was there coercion? Was there grooming? Where did they meet the person? Did they meet them online? So that happens routinely in sexual health services for under 16. There are robust systems in place. Now, it does, if it was a statutory rape, if it was definite sexual assault, we would open it up to police and social work, yes.
So I guess, just to expand on my question, if I may, very briefly, is if somebody, a 14-year-old girl came in and said, I've just been raped, and I want you to examine me because I want to press charges. If she understands the landscape like that, would you proceed? Would the Archway or equivalent proceed with a medical examination to take samples?
Yes, they would. They definitely would. So a 14-year-old who came in who within 7 days who said a sexual assault will be managed with forensic samples, and there'll be a paediatrician or a forensic examiner or both will examine her properly to get all the evidence they need. The challenge for self-referrals for under 16s is if they come in and they don't want a police involvement, and obviously if it's barn door clear that it's a sexual assault and it's an older partner, a neighbour, a family member, that's easy. But there are difficult scenarios, and we have to remember, we operate for 13 to 15-year-olds. We work on the age of legal capacity. We would allow them to have contraception. We'd allow them to go and have a termination, provided they understand all the risks and benefits. So it's quite hard to say across the board all under 16s are going to have police involvement and can't self-refer, and that's the challenging bit. But I'm quite confident that we can put things in place to mitigate that. We would encourage police reporting, of course. We would be looking at the risks of reporting or not. And the main thing for us is to keep these kids engaged, because if we become too intrusive and too dictatorial and too black and white, they just go underground. And we don't want that. So we link with social work, we link with schools. We've got 2 lifestyle nurses here in Lanarkshire who are working with very vulnerable, chaotic adolescents. There's a lot going on behind the scenes. Quite confident we can put things in place to make that robust. But I do think to limit self-referrals to only over 16s is a missed opportunity, yes.
That's
Thank you
very
much. I'll bring Alex Cole-Hampton back in a moment. Can I remind members, though, not to talk across the witnesses? It makes it wish to hear. Alex Cole-Hampton.
No, that was it for me, Convener.
You're all done? Okay, thank you very much. Emma Harper.
Thank you. Thank you, Convener. Good morning again, Dr. McClellan. I absolutely agree that this bill is the correct way to move forward to have a more holistic, person-centred health approach. And I've got a couple of questions about the financial implications and maybe what those implications would be for the health boards. And in the NHS Lanarkshire submission, it highlighted concerns that the bill will lead to additional resource requirements for health boards in the longer term. And part of the submission highlighted that additional resources will be required for adequate staffing, ongoing training, psychological support for the workforce, the victims, storage facilities and suitable premises, as well as family support and equipment and everything. So it's a very broad financial implications for this bill. So I'm keen to hear whether you have any concerns regarding the long-term funding of the statutory provisions of this bill.
Yes, I think we do have. I do have concerns about the long-term funding. So at the moment, even for follow-up alone of patients who've been sexually assaulted, there's several visits backed into the health service. So maybe somebody will come back at 1 week or 2 weeks for a sexual health screen, 3 weeks for a vaccination. They may be put on to post-exposure prophylaxis, so they'll have a month of anti-HIV drugs. So you could have a follow-up for a sexual assault can be 6 appointments already. And that is going to become bigger with self-referral and also with once this bill goes through. So the actual clinical workload will go up and the follow-up will go up. And I suspect that with awareness raising following the bill and the promotion of self-referral will mean the numbers go up. And I think already the number of sexual assaults has gone up. We saw an 8% rise in the number in Scotland in the last 2 years. So, and it's very difficult to cost all of that. And there will be a need for mental health resources, CAMS, community and adolescent services. So all of these services are going to be needed, and alcohol services, maybe drug services. So the package of care is not going to be small, and that alone will it is going to require resource that's going to increase. The storage, as I say, it's freezers. Yes, there'll be some cost implications for that. The building will require maintained. The travelling of victims, all of these things, and the nursing workforce. I am quite confident the nursing workforce could be tapped into help. And again, there are sexual health nurses working across services who could be used, but it does mean a transfer of resource from things they do already. I think we can transfer resources maximally, but I think there'll still be a financial pressure on boards to deliver this, and it will be a question of redistributing resource if there's no additional resource, if that makes sense.
Very much. Emma Harper.
Thank you. That's actually really good to hear the wide range, and the nursing workforce is interesting as well if we're transferring certain skills and services. Today's International Nurses Day, and so widening that ability to have the workforce, I guess, supporting the forensic service is good to hear. I'm just wondering if you think sufficient consideration has been given to the increased costs, and you're describing the increase in assault, and we're hearing an increase in assaults during this coronavirus lockdown as well. So all of these issues considered, do we think that further consideration needs to be given to the financial implications?
I absolutely do think the financial modelling has got to be really thrashed out, because what we don't want to do is open up a service that's then not sustainable and go backwards. So in the cost modelling and the financial memorandum, there's 3 levels of what was the predicted number of people coming in for self-referral, and I think you have to go for the high one, which was an additional 90 cases per year. I certainly think it probably needs looked at again to really cost how many patients are going to come forward if this bill goes through. So, and for example, I mean, I can tell you the data. So just as an indicator of this, I have a report I can try and show up. I don't know if you can see it. So this is 2019. Probably can't see this. I'll send this. I can send this electronically. So last year, we've got the data from Archway yesterday asking about how many sexual assaults were seen, and for Lanarkshire there were 66. 61 were police referrals. Only 5 were self-referrals. I think that the self-referrals are not so willing to travel into Glasgow, and I think that will change once you're delivering services locally. So I think that figure will go up. So I think in the financial memorandum, you need to cost the self-referrals at the highest level. And one of the reasons also is there were only 66 people from Lanarkshire seen in Archway last year. But we yesterday ran a report just quickly off our electronic records that we have in Lanarkshire. My IT person, the shielding, just did a quick snapshot. In the last 12 months, we have had something like 29,000 patients in Lanarkshire. But she had 118 of them who said they'd had a forced sexual assault in the last 12 months. So 118, and this is in the last 12 months. So I don't know if that includes the Archway figures or not. We'll need to look at that. But our records are indicating a much higher number than are coming forward, and that's got to be. That's the big risk for the financial modelling, that we don't. It could be much bigger for patients coming forward than we've costed for. And I think also you'll see in the financial memorandum that Lanarkshire is not anticipated to require any more patients seen, because we also already have self-referral into Archway, but on a practical level, patients are not self-referring into Archway. And also, Archway has been operating very understaffed for the last couple of years. When they were using comms in the out-of-hours service, there was no capacity for self-referral. Because the comms are employed by police, so they saw no referrals after 5 o'clock. Not last year, but the year before. So the self-referral, I think we've got to be cautious that it's maybe an underestimate. I definitely think for financial modelling, we want to be erring on the side of larger numbers coming forward. Now, they might not all go down the court route. That's the only trade-off. The good thing is costed for quite a lot for the justice process, but not all the self-referrals will go down the justice route. So we might see more people coming forward needing forensics, but we might not see the knock-on effect of 100% court cases. If that makes sense.
Thank you very much. Just very briefly, Anne McKellen, going back to the questions I asked at the outset, if a health board is putting in place the facilities it needs and the staffing is made available for 24/7, how much of a difference to the costs does it make if there are 90 self-referrals or a different number?
Oh, for the 90 additional per year?
In other words, given that some of these costs will be in order to implement the bill, and regardless of the number coming forward, how much of the extra costs that you've described are going to have to be incurred anyway, regardless of the level of future demand?
I'm not sure. Sorry, I'm not sure. I'm not sure how to answer this. My understanding is the unit cost for one patient seen is in that financial model. Not sure where they came from. So it was 3,000, 3,100, 5,000, 12,000 for Shetland. I think they would need, if we were operating 24/7 and say we would need to look at staggering patients, if that makes sense. I think what you is, I don't think I can answer that, to be honest. Part of the reason is we've not had a fully staffed service, and we've not looked. I think once we have a fully staffed running service, what I can say is Archway are doing much better now, and there are more in-house examiners. They're operating till midnight, and that's definitely helping. So I think it's a stepwise thing. I couldn't give you a figure on the cost on that. It would need to be.
No. That's the fact that figure is not readily available is important enough, and it's something to pursue, I'm sure, with other witnesses. Can I now ask Miles Briggs? Miles.
Thank you, Convener, and good morning, Dr. McClellan. Thank you for joining the committee this morning. What is your view on a public awareness campaign around self-referral, and how do you believe that should be coordinated?
Anne McClellan.
I think certainly for a self-referral campaign for public, it would need to be 16 and upward that we pushed. I think, see how that went first. I don't think we would do a public awareness raising campaign for self-referral for 13. So I think we should focus on 16 and up for a wide public awareness campaign. I think it could be done through the usual media, through police, through television, there's through an app. I think there's plenty. Health promotion teams around the country are well versed in delivering these messages, and I think that's who we would use. We'd use the Health Promotion Specialists National Group, and there's a health promotion specialist team in every board. There's a lead group. And I think they would come up with that would be not a problem for them to deliver that.
Miles Briggs.
Thank you for that. And in your experience, how do you think health boards will be able to take into account inequalities when implementing this legislation and ensuring that the bill can actually improve equity of access to services?
Anne McClellan.
Well, I mean, as you know, there's more. We have high deprivation in Lanarkshire, so we are quite familiar with targeting services into the areas of deprivation. So we're always looking at postcode data and SIM data, Scottish Index of Multiple Deprivation data. I guess we should be capturing who's coming into services already, and maybe the data group are doing that. If they're not, we can do that. And then looking at So for example, in Lanarkshire, we look at the postcode of people coming into our young person services, and if we find a high number from Airdrie going into a different service, we'll put more into Airdrie, or we might find we've got nobody coming in from Airdrie, and then we will address that. So I think it would be similar. We'll be looking at the data of postcodes, Scottish Index of Multiple Deprivation, and then we would need to also take advice from third sector about where they would want services targeted, and what I mean by that is not just where people live. It might be that we want to go to domestic abuse and try and promote the service more through them. Or I would take some advice. Probably from our health promotion people here, who would usually have the data on. Yeah, they would probably give us that intelligence. But really, postcode data is quite good in Scottish Index of Multiple Deprivation. And I guess if you found you're having cluster from one, if there may be a board that will have a higher rate, I would expect North Lanarkshire to have a higher rate than South Lanarkshire. So we would, we would be targeting more into North. We usually target more into North for if it's something that's related to deprivation. So it's just using the intelligence, really.
And finally, my final question, in terms of ethnic minorities and also people with language barriers, what do you think needs to be done as part of the bill to look at how we provide services and take away some inequalities around the BAME community, for example?
So we would go to Haina Sheikh, who gives us the intelligence on that as well. And I think again there's been a lot of work with bloodborne viruses through faith and ethnic faith groups. So through mosques or through the Chinese. We have workers for Waverley Care, for example, who are tapping into the Chinese community. So we could use that intelligence. Obviously, we need interpreting services, but actually getting the message out there would be done in a similar way we would do for bloodborne virus testing. So, for example, Hep B is a problem in the Chinese community. We would use workers and similar. Look at what's out there and start using it already. Interpreters are fine unless it's if it's a language that's not very well known or a dialect that's not commonly used. Sometimes there's a problem because there are not very many interpreters, and the patient may know the interpreter. So that's something I think we can address that by using someone from the board. It's not ideal doing telephone interpretation, sexual assault. It's not ideal for a lot of people using the telephone interpreting service. But we can work. Actually, what Google Translate is excellent, to be honest. And I've done consultations with Korean women on their phone when I've had to, not for sexual assault, but for a coil fitting. But at least I know they're reading what I'm telling them, and there's no one else involved. And I've managed to do that with somebody from North Korea at a private clinic where I was busy. So there's ways around things. That wouldn't hold up for a forensic setting, but at least we could get onto the Google Translate to say we need to sort this out, hang on, common sense, really.
Another mechanism for remote working rears exactly. In front of it. Thanks for that. And can I now call Brian Whittle?
Thank you, Convener, and good morning, Dr. McClelland. One of the issues that's been highlighted in evidence to the committee has been the importance of psychological and mental health support and supported decision making and the importance that advocacy play in the recovery of victims of sexual assault and rape. So can I ask in the first instance if the bill should give victims a right to advocacy service and the importance you would place on this?
Anne McClelland.
I think that's very important. I think the advocacy and the psychological aspects are very important. In fact, for me, they're the bits almost not out with my control, but they're the bits that we need backed up, because even with a good clinical examination, a good forensic examination, doing the advocacy so that the woman has the support through the court process, preferably with the same person, and that starts from the moment of engagement. I think that's really important. And I think the emphasis should be on getting the advocacy in early and the clinical care in early, and almost the forensics and police are not secondary, but the advocacy and the clinical care is paramount at the start of the process. And I think if that's done well, then you're going to get better outcomes for everybody. The psychological support, I absolutely think, is extremely important. And as you know, mental health services are under huge strain, and they will be under even more strain after this corona outbreak starts to settle, and however long it will take. It does look like at the start, people coming in for a forensic examination, part of the package of care is a psychosocial assessment. It's quite brief, but we would be looking at, it is included, it's part of the care. We would be wanting to know if people were safe. We do ask about they've had mental health issues. They do get a brief suicide assessment and self-harm assessment. But the advocacy worker in Archway, in rape crisis and Archway, the support is really crucial, because they are the people that keep in touch with the person once they've gone home. And we can refer to GPs, we can refer to mental health services, but I think the advocacy work is really crucial. And I think also the psychological impact, often it's later than it's not the first 24 hours. So while there might be an assessment of that being made, it's the ongoing support. And certainly we've been looking in the West of Scotland at a clinical pathway. One of the things we discussed the last time was that sometimes, even with the best psychological support, once the court process starts, everybody has pulled back by then, and so the advocacy worker can keep that going and probably link them back into services they need again at the time of, for example, the court trial starting, or at times in the future where they might be more vulnerable. So I think it's very important. I think the advocacy person, ideally being engaged from the start and seeing them through the whole process, is definitely an essential component.
Brian Whittle.
Thank you, Convener. Thank you, Dr. McClellan. Finally, if I could say, you're indicating there that there is, to an extent, NHS boards are providing sort of immediate and ongoing psychological support to victims of sexual assault and rape. But to me, the key here, what you're highlighting here, is a continuing advocacy service from start to finish here. I think my question would be around, where that currently stands and how much we would have to upskill and how the system is prepared to handle that as it currently stands.
McClellan.
Yeah, well, I think that the rape crisis centres are keen to help with this, and it may be that somebody's allocated at the start. Obviously, they can't be there they would be overwhelmed if they had 20 people for a year and a half, but it may be that they could tap in and out at certain times with that, just touch base with that person at 3 months, 6 months, 9 months. From the psychological point of view, the GP can be a good link if they're linked into mental health services. So there's separate things here. The advocacy workers kind of taking them through the court process and supporting and giving but the actual formal counselling services are a bit separate, and we've not got that clearly thrashed out, to be honest, but there's a need for both, I'm trying to say.
Thank you very much. Brian Whittle.
Thank you. Another question sort of sprang to my mind there, Dr. McClellan, and it was around the impact of the third sector and how we utilise the third sector and bring that into the fold, if you like. Where are we with that just now, and how important will it be utilising the third sector going forward?
Well, it's very important. So we have good links. The links, to be honest, have been haphazard in the past because there's now a chance that we'll get more consistent service for everyone. So at the moment, we are working on a pathways in the west of Scotland, and Lanarkshire the rape crisis are with us round the table, and they are really keen to get involved. I think that it would be ideal if voluntary sector like rape crisis were involved from the very start of when a person hits the service. What tends to happen is their patient will be seen, have their forensic package, go away and be given information about rape crisis, but it would be better that they're linked in right at the start of the process for a face-to-face. And that's kind of what we want to try and do. And not everybody will want that.
Thank you very much. That's very helpful. Just finally, Dr. McClellan, a number of the comments you've made have been in relation to issues around recruitment and around staffing. I think you mentioned some delays in Glasgow because of staffing in the last year, difficulties recruiting to the existing archery service, things that I think we all know about, we've heard from other witnesses. You mentioned networking and you've talked about resources. What is the single most important thing that can come along with this bill in order to make it a reality? It's great to have legislation that strengthens the system, but clearly that's only as good as the system can be made in practice. And you've identified some of the practical challenges that are there now. What should government be doing to back up the bill once it's brought into force?
I think after the bill, I think there needs to be a really strong network between police and joint working with police. A clinical network linking with police, with bringing in the voluntary sector. So the same pathway of care for everybody going through wherever they are. Networking is the thing, so that we know who the local police, they know what's happening. I think also there's not time to start training a whole batch of new young female doctors. That is going to happen. That will be happening, but there are already quite a lot of female examiners out there who could be brought into the network. So I think while the training's important, and I think we should be bringing the nurses into the training too. So I think there's got to be a network where people are linking in, and I think that probably there needs to be some multi-agency policy document come out after the bill, I guess, looking at to progress it and driving forward the implementation through the leads in sexual health, through the police. I mean, even I didn't realise that sometimes patients are signposted back to 101 to report a rape because there's not always a dedicated rape team in the police. Things like that. Well, we don't know that. If we knew that, we could work better together. So, joint working, multidisciplinary working, getting the service a lot better.
Excellent. Thank you very much. That's been a very helpful session. I know members have all appreciated your answers. We have one or two points which we may come back to you on, and we'll certainly be seeking further comments from others as well in relation to the issues that you've highlighted. So thank you very much for taking part in this morning's meeting.
Okay, thank you.
That concludes the public part of this morning's meeting. Our next meeting is provisionally scheduled for a week tomorrow, Wednesday, the 20th of May. This will be notified in the business bulletin and via the committee social media as usual. As previously agreed, I now will suspend the meeting for 10 minutes and move into private session, which we will do by a different medium. And therefore, I suspend this meeting and we will resume at 10 minutes past 11. Thank you very much.